Good afternoon, everyone. Is this turned on?
There, good afternoon. Now you can hear me. Thank you. Thank you for coming today. I'm Melanie Fisher from the Global Health Program. And this is day 3 of Global Health Week and also Diversity Week. We encourage you again to participate tomorrow. We have a speaker, 2 speakers from School of Pharmacy. There is a student speaking to, no, a resident, I'm sorry, resident, Dixie Sheehan, and a nursing student tomorrow as well. So I hope you'll tell your friends and colleagues to support them and come at noon and hear their experiences. And then on Friday, our internal medicine global health track residents will be speaking on a panel here at noon. So I hope you'll attend that, and there will be free pizza that day. So maybe that's an incentive too. So we hope we see you. So thanks so much for supporting Global Health Week. Today, I'm really excited to present and introduce to you Dr. France Weaver, who will be speaking to us. Dr. Weaver is a health economist, and her research focuses on the factors influencing health services use among aging populations, mostly in Europe and the US. In 2022, she joined the WVU School of Public Health as the program director of the Master of Health Administration. She holds a Master of Science in Economics from the University of Lausanne, Switzerland, and a Ph.D. in Health Policy and Management, with emphasis on health economics from the University of North Carolina at Chapel Hill. We are just delighted to have her today and appreciate her participation in Global Health Week. The title of her talk is Global Aging: How to Sustain Our Social, Economic, and Health Systems. Dr. Weaver, thank you.
Thank you, Melanie. Hi, everyone. It's a pleasure to be here today because typically I interact with colleagues and students from the School of Public Health. So it's nice to be able to talk and meet people from other departments and schools in the health sciences campus. So first, I want to say a few words about myself. I was going to try to, no, it's not working. It worked for a second. I was excited. Let me try again. All right. I was trying to make you guess where I am from, using some cliches, right? But still, watchmaking, chocolate production, awesome train systems, the Alps. I'm just emphasizing cliches right here. But I grew up in Switzerland. And it kind of shaped who I am, right? The culture we grow up is really shaping our personalities and interests. So I came to the US in 2000 to get my PhD. And so I have been here for a while, and I'm very excited to say that a month ago, I got my US nationality. Right? It was a great moment. So I am a health economist, and I'm going to start by defining what health economics is about very broadly. And I'm also directing the Master of Health Administration. And, you know, when you think global health, you think scholar/practitioner partnership to better health of the population we serve. In some way, health administration is also coming from that angle, right? Preparing the future leaders of our health system to better the population we serve. So what is health economics? Often people think of, as soon as you hear the term economics, people think about the financial resources. It's broader than that. When you think economics, it's all kind of resources. It's the financial one, but it's also the human capital one, right? People education, people socioeconomic status. It's also time availabilities of people. It's also resources, informal resources, the networks that people have. All these factors are taken in consideration when you think about health economics. And the goal of health economics at a very high level is to maximize the well-being of the population in the context of limited resources. We all have needs and desires, but we compete for those with other people, right? And we have limited resources. So how to allocate all these resources, financial and non-financial, in a way that maximize the well-being of the population. That's really what we are interested in. So as Melanie said, my research focuses on various aspects of aging and how these aspects impact health services use or spending. I conduct empirical analysis, so I use observational data, large data set, to try to get at causal effect, which require some fancy econometrics methods, right? But that's really where my passion is. And here you have some example of the topics that I have been and I'm still working on. I'm looking at Meals on Wheels services. I'm very interested in the Medicaid program. The Medicaid programs provide insurance to people with low income in this country, and the program are state specific. So there is a lot of heterogeneity in the population covered by the Medicaid program across states, but also the services that are being covered. So it's very interesting to analyze how this heterogeneity allow people to access the care they need or not, okay? And I'm also interested in all the population physical activities. So today's talk, population aging, so that we are all on the same page. When I mention that, I am thinking about the demographic profile of the population. Typically, you may, at the aggregate level, at a country level, you could measure population aging by the proportion of the population that is 65 and over. You can also measure it by the dependency ratio, that's the number of people who benefit from social program, typically the 65 plus population, over the population that fund these programs. You can say the 20 to 64-year-old, right? So very simple metrics that give us a glimpse into the aging of the population. So worldwide, the 65 plus population will reach 1.5 billion by 2050. To give you a sense of the scope, it's more than the population of South America, Central America, and North America combined today. So it's a lot of people. Right? And each country in the world experience aging for different reasons. But the issue created by aging of the population are fairly similar across the globe. All right, so to reinforce, to give you a sense of aging worldwide, all right, by 2050, in Europe, 1 in 3 people will be over the age of 60. In the US, it's more than 1 in 4, or North America, I should say, sorry. And it's true in many regions of the world. And in Africa, the proportion is much lower, but it's growing as well. When you talk about aging, it's very easy to focus on the second half of life, right? So typically the population 65 plus. And here you see that's projection from the United Nations, and you see the orange group, the 65 to 84, and then the burgundy group, I guess, 85 plus, right? So you see that that group worldwide it will be growing. Okay. However, when you talk about aging, you immediately have to think about the younger group, the working age group, if you want. That's why here I give you the number for the 2064. because in a lot of countries across the world, they are the ones that fund the systems, right? The old age systems. All right, and you see that the projection indicates that it's fairly stable worldwide. Worldwide numbers are wonderful, but it's more interesting to look at country-specific numbers. All right, to show you a little bit of the heterogeneity in the aging trajectories of the populations. All right, so let's start with the US. So the overall slopes indicate whether the overall population is growing or not, right? So it's projected that in the US, it will keep growing, okay? You see that the 65 plus proportion is increasing, and the 2064 is decreasing. So immediately, red flag, are we going to have enough people to fund our, programs that serve people who are 65 and over? And it's interesting to look at other countries. I think, I'm not going to discuss all of those, but look, for example, at Democratic Republic of Congo. We see a huge increase in the overall population. In that country, like in many countries in Africa, in sub-Saharan Africa, the working age population will keep growing, which is a good thing from an aging perspective. But we also see that the number of people in the second half of life is also increasing, right? Okay. You see in China or the Philippines, the projection are a decrease in population. In China, it's also interesting to see that the working age population will be contracting, right? So all these countries have to think about how to sustain their social programs. When I say social program in that talk, I'm a bit, maybe I abuse the terminology, but I mean retirement systems, I mean health systems, some of the disability support provided to people and so on, right? So forgive me for the lack of rigor, but that's the idea. All right. So overall, we know the 65 plus population is increasing both in numbers and proportion across the world. The populations that sustain the aging population is either increasing or decreasing depending on what you look at in the world. And I want to mention that in high income countries, so, some Asian country, Europe, North America, plus a few others, over the next decade, the population growth will be entirely driven by immigration. So people who emigrate in these countries are coming from other countries. So it means they are leaving these countries, which put an increased pressure on the aging of the population in these countries, which are typically lower and middle income countries, okay? By 2050, the vast majority of the 65 plus will be in low and middle income countries. And when we talk about aging, we still have to consider what's going on in regions like Africa. You have large young groups, but it's combined typically with high mortality rates. So despite the younger age of this population, we observe that it ages at a very fast rate. So things are changing very rapidly in these countries. All right, so when I proposed the topic of this talk, I think I was a touch too ambitious, right? Because how to sustain our social service, there is a lot of heterogeneity across the world. So I think, I will talk mostly about issues that are currently relevant to the high-income countries, but I will tell you that at the same time, emerging economies and lower-income countries, because they see the demographic transition occurring, they start to think about the same issues, right? So what we experience in the US, for example, will benefit, hopefully, in some ways, the policies of other countries that are a little delayed in their aging process. All right. So here I'm going to focus on the demographic factor influencing aging. There are a myriad of other factors, right? And I will talk about our beloved baby boomers, increasing life expectancy and decreasing fertility rate. First, our baby boomers, right? Like when you see a noticeable increase in the birth rate, which is outside the usual trend, right? So for the US, you see a decreasing trend in the 20th century and early 21st, right? With a bump in the fertility rates. That's our baby boomers. So in Europe and the US, that's roughly speaking people who were born after World War II. So 46 to 64, it depends on the country, right? Okay, but there are a multitude of other baby boom across the world at different time period, right? So the baby boom consequences are relevant regardless of which country you focus on. But just to give you a scope for Europe and the US, currently about 1 in 5 individual is a baby boomer. All right. So often when we talk, and I'm going to discuss our health system a lot today because we are all in that world, right, of health services, or most of us. When we talk about the growth in health spending, it's largely driven by our baby boomers. I want to emphasize that a lot because often people believe the growth in health spending is driven by the increase in life expectancy, which may or may not be true. But what we know, and I'm going to discuss that next, but what we know is that we have that massive amount of people who are entering into retirement age that will have growing care needs because they approach slowly the end of life. They are the one using extensively our health systems, right? Okay. All right. Next, increasing life expectancy. And I know most of you are aware of these numbers, but they are so striking. It's always good to look at them because that's a huge achievement of the 20th century, right? This incredible increase in life expectancy. All right. So it's in French because I took that from a French publication, but it's about women. At age 65, how many years can a woman expect to live? That's worldwide numbers, right? In early 1950s, if you were a 65-year-old woman, you were expected to live on average 12 more years. Nowadays, it's about 18 years. And by the middle of our century, it will be 20 years, right? So, which is very impressive, I believe. So it's very tempting to say, okay, all these people living longer, they put a ton of pressure on our health system or even on our retirement systems, right? Well, it depends on whether these years gained are in good health or not. If this additional year of life are spent in good health, that won't impact our health system too much. If they are spent in poor health, then yes, it puts a pressure on our systems, right? That's what we call compression or expansion of morbidity with increasing life expectancy, all right? And out there is a mix of evidence on that. Overall, until recently, it was mostly documented that there has been a compression of morbidity. So people live longer, but a lot of these year gains are in good health. Meaning people really use care at the end of life, in the last 2-3 years of life. That's when most of utilization occur. Most of the spending occur, okay? Obviously, we have behavioral health concern in the US, overweight, obesity that lead to all kinds of medical conditions that can start to change, to change whether we are in a world of compression or expansion of morbidity. All right. Last, the declining fertility rate. They are so striking that we need to think about those, because ultimately it will impact the number of people who can contribute to our social systems. Why? Because in a lot of countries across the world, our social systems are funded through the labor market. And to give you a couple of concrete examples, in the US, when you work, you pay a social security tax, I think 6.2% of your earnings, and you pay a Medicare Part A for hospitalization tax, which is 1.45%, I believe, for the employees. The employer pays the same, right? Okay. So if you think in the US, Social Security and Medicare Part A are funded through our labor force. All right. So now, you understand why it's so important to look at the size of that labor force, right, to sustain our model. And if our fertility rates are really low, sooner or later we'll have a huge issue to sustain our social systems. And you may have heard that for high-income country, the rates that allow to maintain the same size of the population in the absence of immigration is about 2.1 births for 1,000 women. In the US, we are now below that. Okay, so not enough babies. And Korea, South Korea, Japan are even lower, right? Okay, so it raised some serious concern. So let's think a little further along this line. If we have a smaller working population, it means that those who are working will have to support more of the people who are collecting benefits, right? Okay. So one of the consequences is what we call the squeezed middle. And it's us, more or less. Meaning, with more people claiming benefits because we have proportionally more 65 plus people, okay? And we have a, relatively speaking, shrinking middle class, okay? It may be very tempting to tax the middle class more to fund the 65 plus programs. Very tempting, especially because the 65 plus population, our baby boomers, vote, right? So they can influence policy quite a bit, right? So they may induce, they may shape the policy related to aging. And if the middle class, the working class population is proportionally shrinking, that group will have less and less policy influence, right? So it can raise some interesting concern. Another thing is, from an economic standpoint, it's the risk of economic slowdown. With the aging of the population, the composition of the workforce is changing, so we can wonder how it will impact productivity, right? But beyond that, it may also incentivize the capital to leave the aging country and to go towards younger countries, which may shift economic power across the world. All right. So the societal impact of aging is very broad. It impacts, that's the one I could think of. I'm sure you can have other ideas, right? But labor market, our health systems, the retirement systems, the intergenerational transfer, right? A lot of our programs are based on intergenerational solidarity. The younger pay for the benefit received by the older, right? It's a model of solidarity that was implemented in more or less first half, middle of the 20th century, one of the questions we could ask ourselves is that, is this sustainable, or do we need to think about new model of solidarity, right? Okay. All right. So, and again, I told you I'm a health economic, so spending, revenues, that's my world, right? One thing I want to point out, and I don't know how relevant it is for all of you, but there are a lot of international organizations that makes projection due to aging. So the impact of aging on our retirement programs, right? Our pension funds, or on health spending, right? And you have all these projections that really focus on the spending, right? And it's a little bit of a glooming view, more or less, right? Okay. But if you make projection only looking at spending, implicitly you say, okay, the sustainability of our program will come from reducing spending, right? Or at least reducing the growth in spending. And if you think about it, we hear that a lot in the US. Healthcare spending are very high. We have to control it. Even ideally, we want to reduce them. As a health economist, I will tell you, well, it's only half of the story. The other half are the revenues, right? What is the impact of aging on the revenues? Okay. For example, and I don't remember the country, but it's a European country. The projection about the impact of aging on health spending were pretty good. A little bit of growth, but nothing massive, because it may be Luxembourg, which is a small country, but you know, large working age group. So the projections are fairly good. And you may think, okay, nothing to worry too much about, right? When you look at the projection on the revenue side, very bad. And so that country, if you want, is fine in terms of spending, but the revenue will be decreasing significantly. Policymakers have to tackle that issue, right? Which is often not discussed because there is a focus always on the spending. Okay. All right. That's one thing I wanted to tell you. I will briefly mention some solutions that people are thinking about to sustain our social systems, right? And then I'm going to switch and I want to talk about a couple of things going on in the US that are also relevant for the rest of the world, okay? So, you know, people have come up with a ton of different solutions to try to sustain our social system. Obviously, as an economist, I will tell you the first one is economic growth, right? If there is economic growth in a country, you generate increasing revenue, therefore there are more resources to fund our programs, okay? Increasing population, you have also heard about that, right? We need more babies. I'm sorry to say it that way, but that's the reality. We need more babies, so we need policies that will encourage people to have kids, and or we have to increase immigration, right? We need more people to contribute to our social system. We can also think about increasing the labor force participation of the 65 plus population. I think in the US, you have more 65 plus people who keep working than in a lot of other countries, right? So some of these other countries are really trying to find ways to keep the 65 plus working. It has advantages and disadvantages, right? But that's a topic for another discussion. Another solution is to reduce intergenerational transfer. And it has already started, including in the US. Asking the 65 plus to contribute more to their own benefits, okay? For example, increasing cost sharing, right? Increasing out-of-pocket spending. Or if you think of in the US about the Medicare program Part B, outpatient, and Part D, prescription drugs, people pay a premium for this coverage, right? So it's moving away a little bit from, it's very different than Part A, where it's our taxes, our payroll taxes that contribute to fund hospitalization, okay, covered by Medicare, all right? Solution on the revenue side, you can look at those. I just want to briefly mention taxation, because again, that's the first thought that comes to mind. If we need more revenue, let's increase taxes. So currently, a lot of countries rely on taxing labor or salaries, okay? But taxation can be on capital gain, it's already in place, right? And on consumption, okay? Most countries across the world rely heavily on taxing consumption. In the US, we have the retail sale tax that vary across states, right? It's a state level thing. At the federal level, we have very little consumption taxes. I think in the US, the federal government taxes gas, smoking, alcohol abuse, and maybe air travel, right? But that's about it. So currently, the federal government is thinking about, is a consumption tax an option for us, right? You know, to achieve that policy goal is a massive undertaking. And again, it has advantages and disadvantages, right? But I want you to be aware that something the Congressional Budget Office at the end of last year released a report discussing how we could tax consumption to generate more revenues for the federal government. When you talk consumption, you have taxation, you have to think tolerance to pay taxes. Tolerance to pay taxes vary a lot across culture and therefore region of the world, right? And again, I'm going to use cliche example, but people in Sweden are fine paying 70% of their income taxes because they receive a lot of benefits from the government. In the US, people would not agree to such a high level of taxation, right? And say it's not right or wrong, it's just a matter of preferences and attitude towards the governments, right? So that has to be taken into consideration when you think about sustaining social programs, all right? Solution on the spending side. Well, Medicare, people are eligible for Medicare Part A at 65. Let's increase it to 70, right? Okay. That seems like an easy policy solution. And by the way, it was already done for Social Security. The eligibility for Social Security was increased from 65 to 67 now. Okay? For full benefits, right? For full benefits, okay? All right, so you may think, okay, let's go for that one, right? Fairly straightforward policy change. You need to think about the consequence on that policy change. It's what we call a highly regressive policy because of the differential in life expectancy across socioeconomic groups. In the US, a high, at birth, right? A high income gentleman has a life expectancy that is on average 15 years longer than a low income gentleman. 15 years difference in life expectancy, okay? For the woman, it's a little less, I think it's about 10 years, all right? So if you increase the eligibility age for Medicare, let's say to 70, which probably is unrealistic, too much of an increase, right? But people who have low socioeconomic status will benefit very little from the Medicaid programs because on average, they may live until, I don't know, 72, right? So they may receive Medicare benefits for about 2 years on average. Whereas high-income people have longer life expectancy, so they benefit from Medicare for many more years. Okay. So if you are concerned about inequalities and disparities, that's the type of things you have to think about. Okay, all right. Let me see what I'm, okay. I told you that I would mention a couple of things about the US because again, I think it applies to the rest of the world. Often you hear because the US is the country that spends the most per capita on healthcare, or the share of the GDP is the highest of all the countries, right, in the world with 18%. Okay. I want to say from an economic standpoint, it's not an issue per se, right? At the beginning of the 20th century, the economy was dominated by the agricultural sector. Mid-20th century manufacturing, now it's healthcare. By itself, it's not an issue. It's because of the consequences of that level of spending that we have to be concerned. Okay. And two issues that are going on in the US, but again are also relevant in other parts of the world, is substantial waste. A lot of healthcare spending are considered wasteful. And the rising healthcare spending exacerbates inequalities. Okay. What do I mean by waste, right? Yes, it may be over-treatment or, inadequate treatment, this type of things, right? But it's not the main piece. One piece is the high prices. In the US, healthcare services, the same healthcare services are much more expensive than in other high-income countries, right? That are at similar economic stages, if you want. And the most famous example is prescription drugs. The same drugs may cost 3, 4, 5, 10 times more in the US than in other countries. Right? And again, that's a very interesting topic that would be worth discussing, but that would be for another time. So we have pricing issues. We also have high administrative costs in this country. And this is a structural problem. Why do we, and we are probably the country with the highest administrative cost. So why is that? Well, think about the myriad of payers. Right? You have a multitude of private payers, you have Medicare, Medicaid, that create the fact that the system is fragmented and lack coordination create this administrative cost. All right. So it's considered that about a third of the administrative complexity in the US healthcare system, a third of the wasted spending are attributed to this administrative complexity. Okay. And there are a few studies that have estimated the impact that this wasteful spending have, right? And it's amount to about 6% of the GDP. I don't know if you realize how massive it is, right? It's a lot of money that is wasted, okay? But again, it's a structural issue that is not going to be solved quickly. The worsening of inequalities, I thought I would say a couple of things that I don't know if you will like or not, right? Because the US health system is based on a market, right? We often believe that, well, in Canada, there is rationing of care, not in the US. Well, let me tell you that in this country, we are rationing care. And the most striking example, and probably the one I know the best, is Medicaid. Medicaid reimbursement rates are low. Often, they don't cover the cost of providing care. Okay. It depends on the state, obviously, but on average, it's true. Okay. As a result, you have physicians who decline new Medicaid patients. And about 30% of the physicians do that in this country, meaning they are willing to see Medicaid patients up to a certain volume. Why? Because they need to generate an income, right? And if you lose money on too many patients, well, you are not going to stay in business very long, right? So that's a reason why you have access issues for Medicaid enrollee due to the low reimbursement rate. Okay. And then you have, across all states, you have utilization restriction. To be able to be reimbursed for certain drug or certain treatment, you have to be pre-approved by Medicaid. And if you have certain condition, you will be declined, right? Again, it's to try to contain Medicaid spending. So yes, rationing exists in our country. I talk about two already. Number three, right? You think, okay, if health spending are increasing, it's good because it probably means that more people have access to care. So it may help reduce inequalities. And on one hand, it may. However, keep in mind that if we spend more and more money on Medicare, for example, and Medicaid, which are funded by the federal government fully or partly, right? Okay. If the spending increase, well, the budget are not expandable to a great deal, right? So the growth in the Medicare program and the Medicaid program may crowd out, may reduce the spending on other programs that are vital for some vulnerable population. Okay, so you have to make a trade-off. We are not going to win on everything, right? So if we want to expand Medicare, we may have to reduce defense spending or social security spending, right? Again, because of this taxation tolerance, right, or intolerance, right? You cannot keep increasing taxes. At some point, you have to make trade-offs. All right. Medicare. And again, what I'm saying for Medicare, I could replicate that discussion for what is going on in Switzerland and Portugal. That's two countries. I work with researchers in these two countries, so I know a little bit about them. I bet it's also true in other countries, right? So Medicare will represent a growing share of the federal budget. Fine. However, the current prediction says that Medicare Part A, again, that fund hospitalization, the solvency of Medicare Part A will end in what, 8 years? That's the most recent projection, right? Yeah. But that has been going on for, I would say, at least 1 decade, right? Medicare Part A is on the edge of bankruptcy, all right? At the current condition of the Medicare program, if we make changes, then we may expand, right? But there is a real concern about Medicare Part A and its sustainability. And think about it. It's an issue from a policy perspective because, again, that's the working age population that contribute to fund Part A that benefits the 65 plus. Right? So the one paying may not see any benefits if Medicare Part A were to really become insolvent. which I don't want to give you the impression of a catastrophe scenario, right? Because if there is a policy will, it's possible to salvage our social programs, right? But Medicare Part A is a very interesting aspect of it. There are all kinds of solutions, again, to solve that issue of the Medicare solvency, but I want to talk about value-based and population health, because I see a lot of young future healthcare professionals in this room, and you are the one who will be on the value-based and population health models. Right? So I think it's important that you think a little bit about that. Okay. Social determinant of health, you're familiar with that. Health status comes from socioeconomic factors, the physical environment people live in, health-related behaviors, smoking, alcohol abuse, exercising, food, right? And healthcare that typically restore health, or the goal of healthcare is to restore health, right? Healthcare contribute to about 1/5 of the factors that impact your health. So healthcare play a minor role at influencing your health. When healthcare spending amount to 88% of the spending on people health, right? So there is a huge discrepancy about what we focus on in our health systems. And again, it's not solely in the US, it's more or less across the world. We spend all of our money on trying to restore or maintain people health, when in fact it amounts to very little to the health of people at the end of the day. Okay. All right. Another image here. When you think about it, about 45% of what we spend is spent on 5% of the population, the polychronic, people who have multiple or who have comorbidities in a chronic fashion, right? Sorry, I'm not a doctor, so my terminology may not be spot on. Okay. So most of the spending goes to a small proportion of the population. Okay. And you have the majority of the population that is healthy and at times need care, right? Break a leg or, you know, a sudden health shock, right? 75% of the population generate 20% of the cost, okay? So the idea is that we need to change that pyramid. We need to reduce what we spend at the top to be able to increase how much we spend at the bottom to try to keep people healthy. Okay, so it's a shift in paradigm, right? Until now, health system providers have focused at restoring people health. And now we are slowly telling you that yes, you will keep doing that, but more and more you are going to make sure people stay healthy so that they don't need care. Okay, so it's a complete shift in the mission of our health systems, if you want. Okay? And it's happening. Medicare stated that by 2030, or CMS, should I say, by 2030, all of their traditional Medicare enrollee will be under a value-based model. What does it mean is that nowadays, providers are mostly paid on a fee-for-service basis, right? Every service you render gets reimbursed by the payers. We are slowly moving away from that model. And it's a slow transition that will probably take a few decades, right? But we are moving towards a model where the quantity of care provided doesn't matter. The provider will receive a fixed amount for certain episode of care or certain conditions. If they do a great job, if it's high quality, they may get a bonus. If the quality is considered not optimal, they will be financially penalized. Okay, so that's the model that Medicare hope to achieve for all its enrollees by 2030. It's pretty ambitious. I don't know if it will happen. The transition has also already started. Okay? The next step after that is to be in a full population health model where I'm going to say health system, but the health system receive a fixed amount per member or per enrollees, regardless of the care need or health status of the enrollees, right? Okay. Right. So it's fixed amount per member per month, regardless of whether the person use care or not. The goal is, well, health system will make sure people do not use care, so will help people remain healthy so that they don't use care, right? Because if they use care, the health system may end up losing money. Okay, that's a population health model. And you may think, oh my goodness, right? Well, WVU medicine. Have you heard of peak health? Right? Okay, and a lot of health systems across the nation are doing that. Peak health is a model when the health systems that traditionally deliver care is becoming a payer, is providing the coverage. So there is integration of the care provision and the payer of care. So that WVU medicine or peak health will be able to look at both sides of the coin, right? How do I keep my enrollee healthy because I am the insurer, right? Okay. While still being able to provide the care needed at high quality, right? Okay, so peak health is an example of that transition towards a population health model. And Chris McCormick is a director of population health at WVU Medicine, right? And he's very passionate about, and he strongly believes that that's where healthcare is heading. Okay, first in the US, but it will be the case across the world. Yeah. Okay, I was going to speak a little bit about my research, but I'm not going to do it, but I would be happy to talk to anyone interested in learning more. Thank you so much for your time and attention today. Thank you. Sorry.
That was a lot of food for thought, right? That was fascinating. Thank you so much for teaching us about this and give us a lot to look forward to thinking about, right? Thank you. And maybe if anyone has questions, we can go outside into the hallway and Dr. Weaver would be glad to answer any questions there. Thank you so much for coming. It was our pleasure to have you, really. So valuable. Thank you so much.